So we really have an eclectic group of people today. And so we're very grateful to you for spending your time with us. Please note that our upcoming webinar on May 14th is a little bit different. We're moving a little bit to something a little bit controversial perhaps, but that topic, as you can see, is about psychedelics, resiliency, and Roots to Thrive model. So yeah, something a little different. We have our wonderful presenter here with us, Dawn Thomas, and we'll also introduce Heather as well. And so I'm just going to come out of this slide deck so that I can read Heather's great bio, so you have a good sense of who you're in the room with, and a great acknowledgement for expertise and knowledge that Dawn brings with us. She joined Island Health in the newly established position of Executive Lead, Indigenous Health, on June 2020. Dawn is a member of the, help me, I'm not going to say that properly. I know it.
Sanemo.
Thank you. Sanemo First Nation on Vancouver Island. Her traditional Nuchat name is, you want to say that just so I don't mess with it?
Atwiak. Atwiak.
Atwiak loosely translates to the one who says the right words about chiefly business. In her role, Dawn is responsible for enabling and facilitating system transformation and service delivery improvements that improve health and wellness and the care needs of all Indigenous peoples across Island Health Service area, including First Nations, Métis, Inuit, non-status Indigenous peoples, both on and off the reserve. Dawn engages with a wide range of senior internal external partners to foster effective partnerships, leadership and service advancement while ensuring an Indigenous lens is applied to the development, review and revision of Island Health's organizational values, governance, administration and decision making. Dawn brings to Island Health more than 20 years experience with Indigenous children, families, communities and leadership. Has worked for the BC government at the Ministry of Children and Family Development and most recently at the Office of Representative for Children and Youth. She holds a Master of Arts in Dispute Resolution and a Bachelor of Arts in Child and Youth Care from University of Victoria. So we just want to recognize that as advanced practice, we acknowledge that we hadn't been doing a very good job in this area. And so we were super grateful as you came along to just share with us your knowledge. I have heard part of this presentation with you, Vic, before, and I was just so impressed and grateful that Dawn, with my follow-up call, said, yes, I will be happy to present. So you're providing just a real essential piece of knowledge and expertise for us today, and we're grateful. I do want to introduce Heather, who's on the line, and Heather is the Director of Knowledge and Practice on the plain sight document that Dawn will be referencing during her presentation. So I'm just going to stop sharing that and I'm just going to leave it over to Heather and Dawn. And as ever, please, if you do have questions, pop them in the chat. Manny and I, Manny's on the line as well, we will do our utmost to just monitor that chat and then at the end, just bring back those conversations. So I'm just going to take myself off video and I'm going to just hand it over to dear Thomas and Heather, to Dawn and Heather, and over to you. What a beautiful visual. Welcome.
Thank you. I'm so pleased to be here and really honored to present today to this group. But first, yes, I'm grateful that Heather Hastings, who is a Director of Knowledge and Practice at the Ministry of Health on the In Plain Sight team, I'd like her to introduce herself before we start. Please, Heather.
Sure, thank you. My name's Heather Hastings. I'm from Sartlet First Nation, which is on the Wasanik territory on Vancouver Island, where I've worked for my community for many years as a health director. Sorry, that sun's right in my face. As a health director, and prior to that, a community health nurse. I recently graduated from Royal Roads in the Masters of Leadership specialization, where I studied using Indigenous methodologies. My study was on equitable access to primary care for First Nations people. And I am now doing my doctorate of social science at Royal Roads, looking at systemic racism in the healthcare system. So thank you very much.
Great. Thank you, Heather. And so Heather will help support with the slides and then also be part of the Q&A after. So thank you, Heather, so much for being with me today. So good afternoon. I'm really honored to be here. My name is Dawn Thomas, and as I said, my traditional name is A'a'wiak. I'm so honored to be here, and I'm calling in from the Lekwungen People's Territory, more specifically the Songhees and Esquimalt First Nation. I'm from the Sinamo First Nation on Vancouver Island, but very close ties to, family ties to the Hupachesa community in Nuu-Chah-Nulth Territory. And in fact, my name is a Nuu-Chah-Nulth name that I received from my late Auntie Hilda from Cayuquet. And my name grounds me in my work, and really honored to carry the name. And often think of my Auntie Hilda when sharing that with you. So really pleased to join you today to talk about the In Plain Sight, Addressing Indigenous-specific Racism and Discrimination, BC Healthcare Report. When Regina was going through who was here, some of you may have seen this presentation, and so I will move through it quite quickly. And for me, the rich part will be the discussion after, and really look forward to answering questions with my colleague Heather. Let's see, so just want to say that the experiences that were collected and shared can be shocking if you've had a chance to read the report. For me, the stories were the most upsetting. However, for Indigenous people, I just want to note that the findings of the review are quite validating. So for decades, Indigenous people have been raising these concerns, and I'm grateful for the report and the work that Dr. Mary Ellen Turpel-Lafond did, because it provides us a bit of a pathway. But I do want to note that for many decades, Indigenous people have been raising these issues. And when I think about the report and the subsequent data report, the initial In Plain Sight report was released on November 30th, 2020, and the subsequent data report was released on February 4th. And both are available publicly on the Addressing Racism webpage. And I noticed some questions about the slides, and yes, we will make them available for you afterwards. But I just want to share something quickly with you. For me as an Indigenous person, I was at a presentation with Grand Chief Stuart Phillip probably 20 years ago, and something he said has sat with me my entire career. When reading reports like this, when reviewing stats, and I have some stats I'll share with you today, when hearing stories from courageous Indigenous people who've had to tell their story more than once, as Indigenous people working in this field, we don't go home and leave that. Those stats represent our families. They represent our brothers, our sisters, our grandparents, and that sits with us when we go home and when we're with our families. So for me, self-care is so important, and I just want to encourage any Indigenous people on this call today, on the Zoom call, to really take care of yourself and practice good self-care and recognize and acknowledge that this is difficult work, and it's difficult to read these stats. They're not just numbers for us. The stories aren't just words on our paper. There are families and communities. So just want to give the space for that. And then the other thing before I begin, I want to start by sharing something that Cree physician, Dr. James Makokis, and I never know if I pronounce his name right, so I hope I do. He had some closing comments at the recent National Dialogue on Racism. And what he said, again, stayed with me. He said, quote, "Racism is hate. The opposite of hate is love." And then he asked us, how will you infuse love into the healthcare system? And that's something that I think about constantly in my day-to-day work when we're doing presentations. And I want to encourage you to ask yourselves individually and collectively, how can you infuse love into your practice on a daily basis? So if we can go to slide 2, please, Heather. So the primary and unifying focus of the review of In Plain Sight was the quality of the experiences at the point of care for Indigenous people, meaning everywhere that Indigenous people access healthcare. And this is an important piece that at the point of care. Often in our presentations and our discussions with healthcare professionals, there's an understanding and sometimes superficial, but understanding of racism and some of the terms, cultural safety, cultural humility. But at the point of care, we're still having families, communities, Indigenous people receiving poor treatment. And there's many examples in the media, there's many examples in the report. And so the interventions that we're looking at need to be at that point of care. And so I'm thrilled on my team that I have people like Heather, who for many years worked in her community and as a nurse and as a health director to help support, and people like yourselves that are out on the front line. We're really looking for your experience and expertise to help support what interventions do we need to make those changes at the point of care. As many of you might know, that this was an independent review of Indigenous-specific racism, and I use that language intentionally. Anti-Indigenous racism has been not widely accepted by Indigenous people, with the anti-Indigenous sounding the connotation quite negative. And so the Ministry of Health and Island Health has adopted Indigenous-specific racism. So the independent review of Indigenous-specific racism in BC's healthcare system sought to reinforce Indigenous human rights in its mandate to review evidence, analyze findings, and make recommendations. UNDRIP, affirmed in BC through DRIPA, and we're the only province in BC that has that legislation, is really central to our efforts in addressing colonialism in BC and across Canada. It's something I'm really proud of, and our work on the team, I have a small team that we've brought together of really wonderful people. Our work, the foundation will be DRIPA, and so anything we do will be looking at those guidelines that have been put forward by Indigenous peoples. So In Plain Sight has called for a greater uptake of standardized terms. And so there is a glossary, and I really encourage people to go into the report and look at that glossary. And I encourage whatever organization you work at to spend some real time on the language that you're using and make sure that everybody's on the same page. Because what was found in this report that Dr. Mary Ellen Turpel-Lafond did was that many people were using the terms in very different ways. And so cultural safety and humility, for instance, were used interchangeably as if they have the same meaning. One person, what racism means to you might mean something different. And so when looking at the system and making the transformational change we need, one of the first steps is what do these words mean? What do they mean to Indigenous people? Why are we choosing Indigenous-specific racism? So Mary Ellen spends quite a bit of time, and we'll be doing this at the ministry with our executive, all throughout the organization, and at Island Health as well. So really focusing on these key terms and concepts. And I want to take a minute to go through them, and many of you may have the same understanding. I hope this isn't repetitive, but I do think it's extremely important. And you don't have to adopt these definitions, but that there's a common shared understanding of what this language means. Language is so important, as many of you know. Racism, and that is the belief that a group of people is inferior based on the color of their skin or due to the inferiority of their culture or spirituality. So that's what at Ministry of Health, what we're saying when we talk about racism. Indigenous-specific racism is the unique nature of stereotyping, bias, and prejudice about Indigenous people in Canada. It's rooted in the history of settler colonialism, and it's the ongoing race-based discrimination, negative stereotyping, and injustice experienced by Indigenous people. It perpetuates power imbalances, systemic discrimination, inequitable outcomes stemming from the practices and policies. Again, I encourage you to spend some time on really understanding Indigenous-specific racism. And throughout the report, Mary Ellen had so many examples of stereotyping, bias, and prejudice about Indigenous people. She captured the top probably 8 or 9, but throughout the interviews, throughout the data gathered, throughout the information she analyzed, many stereotypes about Indigenous people. So prejudice is a negative way of thinking and attitude toward a socially defined group and toward any person perceived to be a member of that group. I won't go through the rest, except I want to spend some time on the cultural humility and cultural safety piece. So cultural humility is a practice. So when we come to our practice and we come with humility and we're practicing in that way, that's the action. The outcome is cultural safety. And so, as I said in the report and in her interviews, Mary Ellen found those terms used interchangeably, or people saying we are engaged in cultural safety and humility, and then not really able to explain what that meant. So cultural humility is the mindset and practice. And she talks quite a bit about being actively anti-racist. You can't just say you're anti-racist, that your actions have to reflect that. When there is cultural humility and actions, proactive anti-racism actions, we'll see the desired outcomes that we want to see on the right-hand side of the screen there, which is substantive equality, cultural safety, and Indigenous human rights. Let's see if we can go to slide 3, please. So this slide is a visual just to talk about the engagement piece. And really, it's quite remarkable what the team did in a very short period of time. Often we talk about the complexity of engaging with Indigenous people in BC because of the 204, 205 nations, the different language groups, etc. And so I really want to raise my hands and acknowledge the leadership and the people that participated with Mary Ellen. So over the course of 6 months, they developed surveys. They opened an email and telephone contact line. They held key informant interviews, had an opportunity to engage with almost 10,000 people across BC about Indigenous-specific racism. The methodology they used was rigorous and comprehensive. And careful attention was given to protect the privacy of the individuals and ensure appropriate data governance standards were met. And additionally, on top of that, there were new data sources that were used, including discussion with experts in Indigenous health, Indigenous rights, and the Declaration Act, interviews with First Nations and Métis leaders, health system leaders, health professionals, educators, and other partners. And what this report has done is given us a baseline of data that we can go back to, whether it's yearly, every second year, and see how we're doing with our interventions and the progress we're making. So it's something I'm also grateful for. In addition, they had a review of literature, correspondence, articles, and other documents. If we can move on to that slide. So I really like this schematic. And as I said, we will share the slides with you so that you can have this and spend some time looking at it. So it captures the findings of the review. So on the left-hand side there, you'll see that Indigenous peoples, it reflects, had extensive health, governance, economic, social, and ceremonial systems. And still today, we have our own medicines, beliefs and values, and work in connection and relational accountability around that. So there were good health and wellness outcomes. And then you'll see settler colonialism established systems of subjection and oppression for Indigenous people. And these new systems were rooted in intentionally cultivated beliefs about the inferiority of Indigenous peoples. The negative beliefs about Indigenous peoples created the reserve and pass system of segregation, residential schools, and Indian hospitals. And on the island here in Sunamo, in my home territory, an Indian hospital where many of our elders still remember and were subjected to horrific things at that hospital. So those, when I think of mental health and access, you know, when we come, Indigenous people come to emergency room or the hospital, that already we're packing that with us. And so I find that that's where some of the tension lies, and there's the unconscious bias of healthcare professionals at times, and not realizing that just coming in the front door that we have this history with us, and it's a different approach that needs to be taken for sure. So in any case, you'll see good health outcomes, colonialism, a healthcare system built on segregation, racism, and discrimination, which leads to poor health outcomes. And as you go through the schematic here, as I said, there were many stereotypes that Mary Ellen and the team came across over and over again. And these 8 or 9 were the top stereotypes that kept coming up very clearly, and some of the surveys that were brought in were very, very difficult to read, but you'll see there, so less worthy, that were drinkers and alcoholics, that were drug seekers, comments like, yes, their kids get taken away, but they're bad parents and that's why it happens. The term frequent flyers, non-compliant, less capable, get stuff for free came up. And misogynistic views of Indigenous women, so that they had the burden of misogyny and racism. So those stereotypes, as you see, leads to discrimination, and discrimination looks like a number of things, and I won't go through all of them. And we've seen that in some of the media reports around the denial of service, ignoring and shaming, inappropriate pain management, medical mistakes. So, and then discrimination leads to less access, and we know less access leads to poor outcomes. So as we review these findings, I want to insert some reflections from Senator Murray Sinclair from the TRC. And I want to share this for a reason. Often when we go and present, I mean, it's difficult to talk about racism, and nobody comes to work trying to be racist. And so sometimes we're met with a little bit of defensiveness, which is normal, or comments like, well, I've worked here 25 years and none of my colleagues are racist and I've never seen any racism, so I'm not sure what you're talking about. And in fact, we had a situation, I won't tell you which health authority, but all well-intentioned people, but we were meeting with a family who had experienced in what they felt was racism and denial of service that resulted in a very poor outcome. And as we had a family meeting and sat around the table, the family was describing, the family was sharing their story, and a physician said to the family exactly that. There is no racism at this hospital. I've been here 25 years and I can tell you I've never seen it. And of course, this inflated the situation and escalated the situation, and the family was devastated. So we stepped in. One thing we realized, we need to meet before we meet with family and talk about how we support families. But of course, he, as a male physician, white, privileged, has never seen racism. That's not a surprise to me. And so why I share this quote from Senator Murray Sinclair is for that. So he says in the TRC, I want people to understand that even those who support doing away with racism, those who believe that racism is bad for themselves, caught up in a system that almost forces them to continue to adhere to policies and beliefs that they don't understand. It comes from a history of racism. Until we address that and learn from it, we can't even begin to fix it. So for me, I share this because the systemic racism, the system is built on that. And so, as he says, for even those who know it's not right, know it's not bad, might not even see it in the systems. And so what I really like about this report, and we'll talk more about it in a minute, is that Mary Ellen creates a pathway. We need to make systemic changes. We need to make legislative and policy changes. Often in the past, cultural safety training was kind of the ticky box. And if you took that, that was good enough. But that won't change a culture in an organization. We need to change systems, legislation, policy. So it's a transformational change that's going to take years to do. And just want to be really clear about that we need to go slow to go fast. So I really like that quote from Senator Murray. And as I said, we'll share some of the links into these quotes. So slide 5 is the findings. And if you just bear with me with a little bit of some statistics that I want to share with you quickly, and not a lot, but just some that stuck out for me. So the review data reveals that 84% of Indigenous respondents reported some form of discrimination in healthcare. 84%. 52% of Indigenous healthcare workers reported experiencing racial prejudice at work. More than 1/3 of non-Indigenous healthcare workers personally witness racism or discrimination directed to Indigenous patients. And the next statistic was the worst for me and hit me and has stayed with me. So 13% of healthcare workers made racist comments directly within the survey. And so for me, that speaks to, well, it's just a number of things, but the feeling that you feel safe enough to make racist comments in a survey about racism is overwhelming for me to see that. And it's not surprising, but it's still overwhelming and extremely disappointing. So as we've talked about, racism limits access to medical treatment and negatively impacts the health and wellness. There's no question about that. So just quickly, you'll see on the left-hand side the problem. So as we said, widespread stereotyping, racism limits access to medical treatment. Indigenous women and girls are seriously disproportionately impacted. And so the interventions need to be focused on Indigenous women and girls. And our team will be specifically looking at those types of interventions. No surprise, public health emergencies, the COVID and opioid crisis are magnifying racism and disproportionately impacting Indigenous peoples. We almost get weekly calls in, even now around the vaccination program and Indigenous peoples experiencing racism when trying to access vaccinations. And another, number 5, that Indigenous healthcare workers and students face significant racism and discrimination in their work and study environments. And I think that's important to say that the students as well. So Mary Ellen did look at some of, examined some of the solutions to Indigenous-specific racism. And although she found good pockets of work, and I want to acknowledge that and really raise my hands to people who have been doing this work for a number of years, that there are programs out there that are working well, but that it isn't widespread, comprehensive across the board, and it's not hardwired into the healthcare system. So she found that current education and training programs were not adequate. And one of her biggest criticism in the report, which is something that's consistent with what Indigenous communities and leadership is telling us, is that specifically much of the training is disconnected from local knowledge and local communities. And not that health authorities or healthcare professionals should be teaching culture, but that there should be a connection into the local community, an understanding of whose territory you're on, who are the knowledge keepers, who are the elders, just that stronger relationship. Often what we were hearing is that the Indigenous community, First Nation, had no idea what cultural safety training was happening inside the health authority. So that's problematic, and we need to make a shift at that place. And also that cultural safety training is on a continuum, that it's not one course. And there's wonderful courses that people have developed and built, and SANYAS training is one of them. And I'm a fan of the SANYAS training. I've taken it myself while I was at Ministry of Children and Families, and I took it at Island Health as well. But that's the head piece, and that relationship with community can be the heart piece. And Robina Thomas, who's up at University of Victoria and was a board member at Island Health, often says the change comes from when the heart changes, not when the head changes. We need that educational piece and that foundational piece, but it's one piece. And again, cultural safety training is one piece of a bigger picture of transformational change. The other piece that I don't think will be a surprise to anybody is that complaints processes do not work for Indigenous peoples. Indigenous health practices are not integrated. And as I said, insufficient hardwiring of Indigenous cultural safety. And Indigenous structures and roles in health decision-making needs to be strengthened. And really want to hold my hands up, raise my hands to Minister Dix and Deputy Minister Stephen Brown for creating this position. I'm the only Associate Deputy Minister that's Indigenous in all of the BC public service, and there definitely needs to be more, and there are no deputy ministers. And so I will be passionate about holding the government accountable in health decision making, but other areas as well. And encourage the health authorities to ensure that there are senior Indigenous people, Indigenous people in senior roles at decision-making levels. It's extremely important. The other, when she's examining solutions, she found no accountability for the elimination of Indigenous-specific racism, including data and monitoring of progress. And so that's something we're hoping to change as we go forward. So key 6, key observations from the data report. So in your work in providing strengths-based and recovery approaches, evidence-based promising practice and training and education for students, clinicians, and managers, decision and policy makers in the mental health and substance use fields, how can you incorporate the data and findings into your work? It's a question that I want to ask you. The meta themes from the data are: Indigenous people are receiving services in a healthcare environment which is skewed away from primary preventative care and push towards secondary and tertiary care and treatment. The data report provides evidence that the lack of primary care results in higher burden of disease amongst Indigenous people. And then the less access to primary care may be driving lower cancer screening rates and higher rates of treatable cancers. And as an example, Pap screening amongst First Nations women is 68% that of non-First Nations women. And cervical cancer amongst First Nations women is 1.6 times higher than non-First Nations women. The emergency room department has become the locus for much of First Nations health, with adult First Nations users 2 times or greater than other residents access to the emergency room. Again, Indigenous women and girls are shouldering the greatest burden and have greater health disparities than non-Indigenous women and Indigenous men. First Nations women have lower access to health services from the prenatal period through to care of young children. The First Nations female death rate due to opiate overdoses in 2020, almost 2 times as high as that of non-Indigenous females. And in the COVID-19 pandemic, First Nations have had an 80% higher COVID rates than other BC residents. Again, with First Nations women overrepresented in the number of confirmed First Nations cases. And as you see there, the report found that the data report specifically, in one specialty women's hospital, First Nations women in 2017-2018 left the hospital against medical advice at a rate 11 times greater than other residents. This and other correlating data inform the recommendations of In Plain Sight. So we'll go to slide 7, please, Heather. And I won't go through all of these, except again, you can have this slide and it talks about, gives a summary of the 24 recommendations. Recommendation 24 is to build a task team. We're in the process of doing that right now. I just noticed Indigenous women, sorry, I missed that, but we can answer some of those questions after. The task team, we started building that task team in January, and I naively thought we'd be up and running in February, but there's been lots of back and forth and lots of engagement with our Indigenous partners who envision the task team quite differently than perhaps Mary Ellen and her team envisioned it. So I can't say too much more about that, except to say that I'm hoping our first meeting will be in May, and that the Minister and our Indigenous partners will announce who sits on that task team as we go forward. So I'm excited about getting started with that work. So the 24 broad recommendations are designed to confront the legacy of colonization and establish a renewed foundation for Indigenous peoples' access to, interaction with, and treatment by the healthcare system. Mary Ellen ensured that the recommendations take a strong human rights approach consistent with UNDRIP. And there's substantial focus on post-secondary, including ensuring Indigenous enrollment, culturally safe environments, and training. Increasing experiences of cultural safety for Indigenous students in post-secondary institutions is absolutely crucial to our long-term goal. A couple questions here that my team has put together to ask and hopefully further the conversation. What is the Indigenous leadership at Douglas College within your program? Do the evidence-based approaches you promote make sense to Indigenous people? How and who do you consult on this? And in your work with psychological rehabilitation advanced practice, what ways can you respond to the essence of the recommendations and align with increased cultural humility and anti-racism to shift behaviors and beliefs? From the data report, we know that the impacts of complex mental health, the opiate emergency, and substance misuse are higher for Indigenous people. In your work, how do you address this? So finally, as you see the last slide here, what is your personal commitment to action out of the findings of the In Plain Sight report? And I always like to start and end with Dr. Makos's wise words. In what ways can you infuse love into your work and into the healthcare system? Thank you.
Thank you so much, Dawn, for a my head is reeling, I have to say. I don't know about other people. That's a really dense and wonderful overview. And I think you call us to be responsible for our actions and to be responsible for next steps. So I know that you asked 3 questions. I tried to write them down at the time.
I'll ask them again.
Sure, good. Good.
Let's see. And to your point, Regina, I want to say that racism was not built by Indigenous people. And so we don't own fixing it. And so I'm so glad to be here today and with you, because we all have, like you say, a responsibility to fix the system. And it cannot be on the shoulders of Indigenous people to fix this. And so my team specifically, we have Indigenous people and non-Indigenous allies because we need our allies to help do this work. First Nations, Indigenous people can have the solutions, but the work needs to be done with non-Indigenous allies as well. So the question is, what is the Indigenous leadership at Douglas College within your program? So important. I'm very passionate about ensuring that there's Indigenous leadership and that there's Indigenous professors so that Indigenous people can see themselves reflected in the programs. Do the evidence-based approaches you promote make sense to Indigenous people? And how and who do you consult with? And what ways can you respond to the essence of the recommendations and align with increased cultural humility and anti-racism to shift behaviors and beliefs? So I didn't talk about that as much around systems, behaviors, and beliefs, but the recommendations are based in those 3 areas. We won't change everyone's beliefs and behaviors, so we need to change the systems so that their beliefs and behaviors cannot be racist. There cannot be an racist interaction, that there'll be legislation, accountability, and policies that hold us to account. But those are 3 questions you can, or if they help start the conversation, but if there's others, I just encourage that time, and Heather and I will do our best to answer those.
Well, thank you again for a really comprehensive presentation. For these compelling questions, I almost think that this might be a time to suggest a follow-up long conversation where we could maybe even have people in breakout rooms. Of course, time of COVID,
yes,
we do so many things online these days. But I know that we have 70 people in the room, and I'm sure we have important answers to those questions. And collectively, I'm sure we could enhance those responses as well.
Yeah, I love that idea. That's a great idea.
Yeah, because I think sometimes in small groups, sometimes it's a little bit easier to be able to, you mentioned at the beginning of this presentation that the work is in the heart. Yes, it's about the academics, and sometimes I think about the heart for sure, and the wisdom, I think, in terms of, you know, practice or proneness, or the practice or the application of ideas sometimes. So yeah, so, but that's not to say that we should not advance this conversation now, but you've definitely given me a thought that maybe we could have a working session with people to to do that more.
That would be great.
Deliberately. And I know that I definitely invited a number of people from Douglas College today, and I know there are people more conversant than I in terms of thinking about what's going on at Douglas College, and we are very lucky to have some incredible people. So maybe others want to, like a whole program. So I think that's a bit unusual for a college. Anyways, I'm going to leave it to other people who are more conversant than I to respond to that. But I think from our perspective, as maybe we can begin an advanced practice. We acknowledged and recognized that this was a gap. We have currently 60 free webinars for people. We're pretty proud of what we do, but we honestly knew, and we've been working for about a year in truth to bring more of this information forward. So we were fortunate enough to have 2 occupational therapists from the Alberta area a month ago who spoke very much about their experience as clinicians and the intersection between the work they were trying to do and being constrained by a particular role within their own context, and some ideas for how we move forward. So that began our work. And then today, having you as well, your team here, and hopefully as well, we have a couple of other pieces in the work that we're looking more at the BIPOC issue in terms of anti-racism as well. And I learned from you, Dawn, the last time you spoke, that the Ministry of Health in BC, they're going to have 2 sections, one of which is Indigenous focused and the other is more BIPOC focused. I don't know if you want to talk about that a little bit more, but I guess what I'm saying is advanced practice. We have a number of people here today. It is an issue. It is something of significance and importance to us. And I think we want to learn. We want to learn more. So I don't want to capture the conversation here, but perhaps others have ideas and wish to type. Shannon adds, Don, I love what you said about Indigenous people did not create racism, and it shouldn't have to rely on Indigenous shoulders to fix it. We need to learn more. So I totally concur, Shannon. Thank you very much for that eloquent response. Yeah, we need to learn more, and I think part of having the privilege of having you here today is to help us begin to think about ideas and how we can move that forward as well.
And I think, thank you for that. Many organizations are in exactly the same space you are. And I know for Island Health, we're very early in our journey of cultural safety. And that's not a bad place to be. And I also want to say Dr. Alika LaFontaine, who's an Indigenous physician from Manitoba, I believe, has done a lot of work in cultural safety and Indigenous-specific racism. He's just been newly elected as the first Indigenous president of the Canadian Medical Association. So yes. Thrilled. Yes. Yeah. So he believes that no institution is doing this in a good way, that we're all so early on in our journeys. And so there's not a jurisdiction that we can go to and say, they're doing this right, and let's take from there. Some of this will be trial and error for us. And so I think there's no shame in being where you're at, and you're doing the right thing by asking questions, learning. These are the steps to take, right? Looking at your policies, looking at your leadership, looking at the practice and how you work together. So just want to acknowledge that you're in the same place as many other organizations.
Thank you. Thank you for the push as well, because I think it's good to, it's good to be a little bit uncomfortable sometimes and go, oh, I don't really know what we're doing. So I think there's true value in just that sense of, all right, let's try and think about one step forward and how we move. Yeah.
Yes, and that humility.
Maybe we'll just go back to Heather and Tina's point about, Tina mentioned just Indigenous women shouldering the burden. Giving sacred caregiving roles means impacts are not just on the women, but often on the next generation, the children, all at the same time. And Heather, your response as well. Taken here that because all of these barriers makes it unlikely that someone would ask to get tested for cancer or PAP, or especially if they have had a bad experience in the past. And it was instructive to learn from you as well, Don, about just the COVID testing and how people are experiencing those terms, in a negative way, and your idea that, people are coming. I think you said they're coming with a package or just that history that people, show up at those places with. And I think people delivering services show up with their own little bags as well. And sometimes, that can get in the way for care. and love.
Yeah. Actually, yeah, and Heather, I wouldn't mind you sharing your story, that the one that I always share, around your experience with an access issue, and I'll let you share the context that you shared with us. I think it's a good example and why I have urgency in this work.
Sure. Yeah. I wanted to just acknowledge the point around the women and how that impacts our children. When I was doing my research around barriers to care and access to care, I did hear a lot from women and mothers who said that it was a barrier to get in the door because they were afraid that they were going to be judged as parents. Are they good parents? Are they bad parents? And lots of them said, like, we would dress our kids up like they were going to a formal event just to go to the doctor, because we knew that we were going to be unfairly judged just walking through the door. And a lot of times that did lead to hesitancy, and then perpetuating, bringing the kids in maybe a little bit sicker than they would have if they knew that they could do so in a safe way. So just wanting to really acknowledge that point. So as I mentioned, prior to working with Dawn, I was a health director and a nurse for SARTLIP. And so I've spent a lot of time coming in and out of the hospital with my community members. And more recently, not that long ago, I was leaving a meeting at Saanich Peninsula Hospital, which is which is the hospital nearby. And I got into my car and I was about to leave the parking lot. And I looked out my front window and there was a community member of mine sitting in their car in the parking lot. And so I jumped out of my car and went over, and they'd been sitting there for hours, and they were too nervous to go in the doors of the emergency room. And they had been there and they were trying to, trying to like muster up the courage that they needed to walk in and ask for the help that they needed. This wasn't the first time. They had come the night before and weren't able to get through the door. And so they had come back the next day and they were sitting there alone, waiting to build the strength and the courage to go in and ask for the care that they needed. This is based off of previous experiences. And that's not a Saanich Peninsula Hospital. I know I gave them a shout out, but that's just the emergency room issue. Whereas people don't go and get the care that they need because they already know that there's a barrier in place for them to be asking for the help that they need. And so I spoke with this person and I went into the hospital with them, and we sat there for hours together, and I sat with him, and eventually we left because that person couldn't, the amount of anxiety that they were feeling going into the hospital, we eventually left. And we went back to the community, and we ended up sort of like doing a lot more of like harm reduction rather than actually the care that was required at the moment. They ended up in the ICU for a few weeks because of this case. And so these are real and they're happening now. These aren't historical concerns, they're every day. And so things like that, and just really seeing our community members struggle, knowing the barriers that they face accessing the care that they need, and knowing that they're going to be unfairly judged, really is impacting their health and wellness, and in some cases it really is life or death.
Yeah.
So
yeah, thank you for sharing that. It's something when Heather initially shared with me, I often share that story around urgency and making changes. And what Mary Ellen continues to find, she does a lot of work now with complaints that come forward, is that real judgment and stigma around mental health and substance use. And so our people that are struggling with that for all the reasons we know why, that results in very negative outcomes for Indigenous people. And so that's something where a lot of work needs to be done around reducing that stigma, the judgment on mental health. And often the situations that we've seen in the media are escalated, and there isn't that trauma-informed lens to the work. And it's not to blame healthcare professionals or anyone. It's just to say this is the reality, and we've grown up this way. Society, the healthcare system is built on these on colonial, there are colonial structures, right? It doesn't mean you're bad because these things are happening as a healthcare professional, but we need to do better. And we know there's society and culture at large are recognizing some of these issues. They're coming up. People are feeling safer to report, which is good, but we all need to take responsibility for making the shifts.
Just not acceptable. I guess Heather just says this is ridiculous, and I guess that seems such a, like it's ridiculous, and it's about somebody's life, and for that, and like to just be that, stymied by those experiences and not to get the help you want. It's tragic. It's just, it's kind of incomprehensible.
Heartbreaking.
Yeah, and the additional trauma of having to wait in the ER for many, many hours and then not getting the support you want must really increase that experience of trauma as well for people.
And I think the Mary Ellen's report, the In Plain Sight report, also does mention that obvious that clearly that not every person has experienced or has an experience of racism in the system, and that's true, but I don't know that Indigenous people know when they will expect to experience it, right? So even just the
possibility of it,
possibility becomes a barrier to care.
Such a good point.
Maybe we can just look at this person who says it's about Accreditation Canada. Whenever I've tried to make service provision tools to incorporate an Aboriginal perspective, I've told it doesn't meet accreditation standards, so that it's a copyright and an intention systematic constraint. Any thoughts about that at all?
That's something I might have to take away and email back a response. I do know there's a cultural safety standard that's being looked at by Accreditation Canada that we will look to incorporate in British Columbia. I believe it's coming up for public review this spring, and perhaps having that cultural safety standard might help in that area that you're speaking to, but it's not an area that I have a lot of knowledge on, and so it's something I can definitely follow up with from my team. And get back to you, and I'll send you a note, Regina, if that makes sense.
Yeah, wonderful, thank you. Yeah, we can maybe just put that on the website as well. But
as a follow-up.
Yeah. I really appreciate you speaking about the opioid crisis as well, and just bringing that intersection of this other hidden crisis that we have, along with everything else, and just how you helped us understand the intersection of and the impact of Indigenous women and opiate use, and just the profound loss that we're experiencing as a result of losing people.
And we share that so that we can be intentional. Like this report does provide, like I said, the pathway and the data and the information, so that we have this information. Now, what are we going to do with it, right? Like, so how do our interventions, how do the system changes that we need to make impact women, and so that we're using that lens and analysis when we're looking at the tools that we need to incorporate going forward. And so I'm, like I said before, I'm super grateful for this report because it does give us the data and the evidence that the system will respond to, and it's the language that the system uses, so that we can make the transformation that we need to make. Other questions? I don't know if anyone wants to raise their hand and ask a question.
I think that's a little bit, I think we have been able to do that once though, but let's see. But definitely, generally people are, I think people are doing a lot of thinking, honestly, Don. I think that's there's a lot of meat to your presentation. So I think people are just likely pondering the impacts, and some of us, we take a little while to process those things, but and probably just a first, an early step maybe for people as well.
Yeah. Yeah, and we're happy to come back and have more discussion and small group discussion. I think sometimes people might feel safer in that small group discussion. But what I want to say is that, like, this is the opportunity to kind of have those courageous conversations and ask those courageous questions. And you won't be judged by Heather or I because, this is a new area in many ways. We're talking about this. It's not something we talked about, 5 years ago. We weren't even allowed to say there was racism in the system. And there's lots of feelings around it as non-Indigenous people when we talk about it. We have Kaz McKenzie, who works with us, that does quite a bit of education around it's not bad or good. You're not bad or good. It's in the system. It's there. We need to address it and work with it. But take this opportunity and please follow up an email or call to ask those questions that maybe you're thinking about and maybe you're worried, am I racist if I ask this question? Like, please, let's have the conversation and we'll do our best to answer. And if we don't have the answer, because we don't always have the answer, we'll try to get it for you and follow up so that we can continue this important conversation.
Okay, lots of comments coming in. So Alex begins with, any thought being given to offer training to healthcare workers, bring together knowledge of the body, stress, neurophysiology, linking that to intergenerational or historical trauma?
Yeah, I love that. Very much when we're thinking of Indigenous ways of knowing and being, and looking at that joint medical degree with traditional knowledge paired up with a more Western model, looking at those 4 areas and how the physical and how the mental impacts the physical, and respecting Indigenous ways of knowing. And so the report very much found that those practices were not respected, and that we need to do a better job going forward. And for me, it's quite exciting thinking of a joint program that respects traditional knowledge keepers and traditional healers. My grandma, the late Dr. Ellen White, was a midwife and healer in our community, and the work she did was amazing, and she supported and helped so many people in our community. And I think she must be smiling down on us now, knowing that there's actually going to be a program in BC that recognizes Indigenous healers in a way, in a Western institution. To me, that's super exciting and really demonstrates, I think, progress. So raise my hands to that work. Excellent question.
I apologize. I got shoved out of the room there for half a second, and so I've lost our chat. There may be a couple of things that I missed in terms of questions. I can see the next post is Lisa, so I apologize. I think there's some things in there. Manny or anybody, anything I missed? I did happen to read the first part of the next comment that just acknowledged the value of having strong people bring this work forward. And I just want to add my voice to that. I think that, just having that strength and informed approach, I think just adds credibility and immediateness. That's not a real word, but to this work. So just want to add my comment to that as well.
Yeah, and someone asked about resources. We can send you some links around different resources and books that you can refer people to around having these conversations and how to have these conversations. It's a real skill, and so there's training programs that will help develop that. But even like addressing racism, if you see it and witness it as a non-Indigenous practitioner, it's difficult to raise it, and so it's a practice, and that's what Mary Ellen talks about in her report. It's not enough to say you are anti-racist. You have to action and address, and it's difficult to do that. And so it's going to take time for all of us in our journeys to be able to do that. So we can, Regina, follow up with some resources and websites that help that. And that's something that the SANYAS training, the more advanced training does. It lets you practice in a safe space around that. So although the report has some criticisms of SANYAS, I think for me overall, it's a good foundational piece to start your journey.
Yeah. So as a team here at Advanced Practice, we're definitely all signed up and ready to do that as part of our commitment to move forward.
That's excellent. That's a really good start.
Yeah. So this person just asking about assessments, but maybe that was part of your last response as well, about for leaders, 360 assessments, for example, that include cultural humility or of cultural leaders. So maybe that's part of your.
Well, no, you know, and what I encourage organizations to do is have accountabilities. Like what for you as a leader, or what are you going to do to either infuse love into your system? How will you make your organization more culturally safe? And so there are measurements and tools and assessments for organizations to take, and we can share some of those with you too, but it can be very simple. And so like at Island Health, Indigenous cultural safety doesn't sit with me as the VP of Indigenous Health. It sits with all the vice presidents. And so everybody has an accountability in your program. What have you done to demonstrate cultural humility or cultural safety? And so even asking those questions in itself, or a 360, I mean, I think people learn more from a 360 than any other assessment, actually. And you can ask those questions in a 360 related to cultural safety and anti-racist practice. But we can share there's assessment tools, and Interior Health, I believe, has done some work. I think it's Interior Health and maybe Northern Health, but we can share some of those with you as well.
Yeah. Lillian just commenting that there's a lot of meat to ponder. I agree. Incorporating the practice of deep listening when working with Indigenous patients, and I guess with everybody really, and to provide that safe, non-judgmental space. It's heartbreaking to hear about people too afraid of being re-traumatized to ask for the help. Really appreciate both of you for your strong voice for change and representation at all levels of leadership. So needed. Now we go further than that, reflecting on the story of the physician leader, what tools for accountability. We only talk about racism when there's an incident happens, but that isn't a response to overt racism, but to get at the covert racism that undermines daily practice, because otherwise we don't want to have those difficult conversations. You know, that's a good point, isn't it?
Mm-hmm. Definitely. Yeah, definitely. So some of the work we're doing, and Heather can speak to this, is we're looking at the Health Professions Act, so that as healthcare professionals, if you witness racism, that it becomes mandatory to report it. And so that is something that the minister is very committed to, and we're hoping to get on the legislative docket quite quickly, so that there's an accountability there for some of those covert situations. I will say, we're getting better at responding, and so just recently there was, for many of you might know about the Colton Bushy incident, and the RCMP were investigated, I guess is the word, and found to have been racist towards the Colton Bushy's family. So there was media stories on this situation, and there was someone from a health authority, an employee, who named himself as a health authority employee, who made ugly racist comments on social media, so bad that people reported it to the RCMP as hate crime. And so the arrogance and lack of humility to name where you work and make those types of comments. So we heard about it from Indigenous leadership. And I have to say, I'm so proud of that health authority that did an investigation within 24 hours, and that employee was let go. And it was a union employee. And there's so many myths about not letting union people go. But there has to be a zero tolerance and accountability when there's racism. And that was an example of just, I mean, and I've seen the comments before, but this was particularly egregious comments. And so I think we're getting better. And there was some pushback, and you know, we had to push and say there has to be zero tolerance for that type of racism. And whether the health authority gets sued or not, for letting this person go, that had to be the response. So I'm super proud of that health authority, that they did the right thing, because Indigenous employees were watching them, Indigenous leadership was watching them, and Indigenous leadership said to us, does that person have access to Indigenous patients? Because that cannot happen. There cannot be another day that this person has access to Indigenous patients. And so the health authority did the right thing and let that person go.
I really appreciate your comment on that, Don. I think the way in which you approach that, I think, is very instructive to myself. I can own. I think just being able to call it out without really contributing to the negativity, but just clearly stating this is not okay, and these are some of the dangers, and it's just, yeah, it's got to stop. Love it. Thank you. Love it. I think just your way of being is just a gift for us. So I appreciate that. Thank you. Yeah. Kelly mentions, I appreciate the openness and holistic approach you're presenting. So often presenting on hot topics feel like blame and finger pointing. I guess I'm saying the same thing. Thank you, Kelly. Pointing non-Indigenous people. By the way, to move forward needs to be safe for all. Both sides of this issue were created long before we arrived. Now both need to move forward and to health and wholeness. Appreciate the space you've created.
So much so, and it's not about blaming and shaming. And even in that example, it's just about accountability for someone. And that is on one end of the spectrum, and someone that probably training is not going to help, right? And there needs to be accountability, just as a quality issue, as a safety issue. But this isn't about blaming and shaming or saying because you have unconscious bias, or perhaps you have stereotypes, because media has stereotypes. And you know, growing up, I experienced, and I'm quite white passing, but I experienced lots of racism. I'm sure Heather has many examples as well. And there weren't good examples in media. I never saw myself reflected in a positive way. And so when you grow up with that, you have stereotypes of Indigenous people. And so not to blame or shame yourself, but then to take the commitment to do the work that you need to do, to feel uncomfortable sometimes, and get on that journey, and learn and educate yourself and connect and build relationships with Indigenous people so that you can practice with anti-racist tools. And if you come with humility, I don't know any Indigenous community that won't embrace you as a non-Indigenous person when you approach our people with humility.
An important message. Thank you, Dawn. Yeah.
Can I just add, I echo everything that Dawn has said, and I think absolutely racism came before all of us, right? And I think that right now we're in a time where the only I don't want to say bad, but I'm going to use bad. It's maybe not the right word, but the only bad thing we can do right now is nothing. Yeah. So I think any step in the right direction towards humility and that self-discovery and reflection and understanding the anti-racism approach to racism, you know, where we're not just not racist, but we're actually dismantling racism, I think is the step in the right direction. So wherever you are in that is the right place to be, and then moving forward from there. So yeah.
Thank you, Heather. Such a good point.
Heather, you shared with us that you were at Royal Roads. I want to say shout out. I'm a Royal Road grad as well. But maybe there's some papers that you've or ideas or thoughts or position papers that you've produced in your journey that you may wish to share with us, and we'd be very happy to share that on our website should you wish, but no pressure. But yeah, I'm trying to do my PhD. Stop, leave me alone. But if there are things, I would be happy to share them and just advance your work as well. That would be great.
Thank you for that. And Heather brings such a vast experience and knowledge, and she often shares research that she's looking at, and so we can share some of those as well. And so I'm super grateful that she's part of our team and keeps us accountable to this work. And I have to say, it's difficult work for Indigenous people, and so for other Indigenous people on this Zoom call, pushing the system and having that burden and looking to make that transformational change, it's very extremely difficult work, and so really want to support and raise my hands. And often organizations don't have support for Indigenous people in those systems, and so I know when the disclosures of racism first hit the media, Indigenous staff at Island Health were very triggered and there aren't traditional supports around to support our staff who witness that. And so we've made some changes to have Indigenous registered clinical counselors, bring in some people to lead circles for our Indigenous employees, but really always want to hold up our Indigenous staff who are in it and facing up against and rubbing up against that tension and that fierce brick wall, I guess, I don't know how to say it, of the status quo, and that people are so afraid of change. And we get that and understand that. And I love Dr. Alika LaFontaine talks about how to support change, and that for non-Indigenous people, there's a loss because things are going to be different, and really acknowledging that there's a loss, and that's okay. And it's not for Indigenous people to fix that loss or heal it, but to acknowledge it, and then we move forward together. When change happens and we move away from the status quo, that there will be experiences of loss in different ways, and just acknowledging that, yeah.
I'm just struck often by the parallels between a recovery orientation and also doing this work as well. Mm-hmm. So many of the similar values in terms of emancipation, for want of a better word, but just the idea of sharing of power, of full inclusion, of person-centered care, of all of those values that shake, I think, or rock the system a little bit.
Exactly.
So critical for this work. Tammy adds, thank you for this most informative presentation and discussion. Just a scoot. So maybe just before we do close down, Dawn, I don't know in this moment, but you did mention that you might be interested in coming back to us. And so yes. what I would propose is that maybe, I know that you're a very busy human, but maybe in the fall, as is Heather, I'm sure as well, but to give you a little bit of lead time, but maybe in the fall, maybe I could propose that we have a bit of a workshop.
Yes.
We would ask people to sign up, and perhaps we come with a couple of identified questions, just really calling on people for your last slide in terms of what are actions that we can do to move forward. And perhaps we would invite people to come join us, and we would have the sort of facilitated breakout rooms where people would be able to, I guess, just have some time to ponder this material and to be able to think about, well, what can I do and what would those next steps be?
Yeah, I love that idea. Really happy for me and some Heather and maybe a couple other people from the team to come, and we'll be able to update on some of the work we've done over this summer period, and the task team will be up and running, so can share some of that information, and perhaps we'll have more tools and etc. that we can share. So yeah, I really love that idea and happy to do that.
Thank you for your flexibility and your openness. That's great. Thank you both. Wow, I'm blown away. That's something very special. Thank you.
Yes, you're welcome. And thank you all for your time today, the work that you do, the hard and difficult work that you do. I really want to stand you up. I'm far removed from the front line, and I have nothing but gratitude for the work that you do with our people. Kliko.
Thank you. Yeah. In my own language, I will say Guramila Mahagat, which in Irish language means 1,000 welcomes, or 1,000 thank yous rather. So thank you very much. I really appreciate it. Yes.
Great. And thank you, Heather.
Yes, thank you. Thanks for having me.
Okay. Look forward to hearing from you both.
Take good care.
Yeah, gratitude. Lovely, Scarlett. All right. Bye for now.